everybody, and thanks for coming back again. We're going to spend a lot of time on a lot of healthcare updates we have today, and I'll turn it over to Dr. Newman in just a couple moments to do that. But I thought since we had you gathered here, I'd start with a little bit of a campus update and take any questions you have on that, and then we'll segue to Dr. Newman. And got a mic over here. I promise for our folks watching on Facebook, I'll try and do a better job of repeating questions as they get asked so everyone can hear them. But let me give you a little bit of a campus update and take any questions you might have on that. So we talked about last week, a week or so ago, that we were going to begin the process of moving students out of residence halls and back to their homes. I wanted to give you a little bit of an update on that. That was a decision made in the interest of health and safety per the kinds of guidelines we're getting from both the federal government and the state. So just by way of context, our residence halls, we house a total of almost 6,900 students. As of this morning, about 4,000 had already checked out. We started allowing students to move out last week. We've already got about 4,000 who have checked out. We'll continue that process through March 27th. We're working with students who we know might have some hardship in some of the dates, working around the remote learning opportunities and needs. And so we'll be working with families who have particular needs around that, but we're working toward moving almost everyone out of our residence halls this week, and about 4,000 have checked out. We have an appeals process with a committee that was put into place because we know there are going to be a number of students who need to stay in residence halls for a number of reasons. They might be international students, there might be some financial hardship involved where they need to stay. We've had about 450 or so undergraduate students who have submitted housing appeals to date. We believe that most of those students, those appeals will be granted. We're in the process starting today of notifying those students. After March 27th, we'll manage those kinds of requests on a case-by-case basis. We use some criteria for how we judge those appeals, around around our goals of minimizing health risk, around supporting students who may have demonstrated financial difficulty or hardships in being able to travel, that kind of thing. So in order to manage that process of having a few hundred students at the very least still on campus with us, we'll be moving those students into primarily 3 residence halls on the north side of campus: Blazer, Jewel, and potentially Boyd, depending on our numbers. That will allow us to do a few things. One, we'll be able to put 1 student per suite in compliance with CDC, or Centers for Disease Control and Prevention, recommendations. We'll have some pretty strict criteria and rules around that. For instance, there will be no visitation in the residence halls. There will be a lockdown on all common facility areas. We'll have desk coverage from 8 a.m. to midnight every night to ensure we're applying and adhering to those rules. We'll be helping students who have appealed and are staying with us. We'll have a kind of consolidation of move-in assistance with carts and front desk coverage to help them get moved. And if a student for some reason can't retrieve their belongings, we'll be working with contract moving services or helping them arrange with friends or others to pick up their belongings. The other benefit of moving all the students toward the north side of campus is our student center is remaining open as primarily a student support area. So Champion's Kitchen, which is the primary dining facility in the student center, is been transformed into a to-go kind of food facility. We serve breakfast, lunch, and dinner there at 2-hour increments throughout the day, and then there's cleaning in between those incremental periods. So that supports both students and staff, and having students on one side of the campus will allow us to better facilitate that kind of support service. The Student Center also becomes something probably of a one-stop shop for different sort of support services, again, to consolidate those sorts of operations so that we can best support services in the right, healthy kind of way. In compliance with all the procedures and protocols that you've heard the governor talk about and others. We'll have more information about that in the coming days, but that's sort of some of the basics around housing, move in, move out that we've got going. One other thing I wanted to mention with respect to campus is a basic needs persistent fund at UK. We've had that fund for some time, primarily to help students who demonstrate some sort of financial hardship or other impediment that might compromise their ability to get their education. So on Friday of last week, our Vice President for Philanthropy and Alumni Engagement, Mike Ritchie, distributed an email to all UK alumni, giving them information about the fund and how to donate to it. As of this morning, some $35,000 had already been given to the fund, with 167 donors from over 24 states. The numbers are growing hourly. We have our Student and Academic Life team has identified a number of criteria, again, for how we determine who receives resources and assistance from that fund. It could be a For instance, a loss of part-time work in Lexington area, as we know, restaurants and other service sorts of industries where our students work, that those have been hurt, and students as a result have lost their jobs. Could be an issue around internet access or connectivity, so students can complete their coursework during this time as we have moved to remote learning or other alternative platforms. Of course, access and affordability around basic needs like food or housing, and then other sorts of things like hardware, computer hardware, such as computers or tablets that might provide students with access to their faculty and courses during this transition. That fund, you can find a link to that fund on the university's coronavirus website, which I think is uky.edu/coronavirus. There's a section on that site pretty prominent about how you can help. You can go there and find a number of resources and assistance areas such as donating blood, but you can also find this persistence fund as well. So I wanted to give you a little bit of a campus update. Before I turn it over to Dr. Newman, do you have any questions about those things? Jacob?
You said staff would be staying in those North Campus dorms, kind of help accommodate students. I guess you need RAs to kind of manage like those people. Is it the RAs that were already working in those dorms?
We're working with RAs who wanted to stay and work. Obviously, we've got some needs there, so we're working with RAs who want to stay and work to provide them with that opportunity in this context. So.
What about the food pantry that you had before this COVID-19? Is that still stocked?
It is still operational. It's stocked. In fact, we've got information on both. There's a basic needs site, and there's also that coronavirus site where we have information about basic needs and what we can do there. But that does remain operational. Okay, great. All right. I know I'm going to turn it over to Dr. Newman. I'll repeat questions after he has some opening comments. We've got a number of experts today around a number of fronts where we're trying to make some moves in response to this crisis. Dr. Newman.
Thanks, Jay. I want to start off my comments the same way I did last time, and which is I want to say to our patients, UK Healthcare is here for you. We continue to have that as our key focus. We want every individual in the Commonwealth to know that if they need us, that we're there for them, and that's the reason there is a UK Healthcare. The second thing I want to talk to is our people. I'm impressed every day that we have individuals that are here in healthcare that, and despite every effort that we make to keep them safe, they're putting themselves in harm's way as they take care of our patients. And I'm impressed with all that they do. I'm also impressed with the innovation and the work we do to enhance and provide even better care in a safer environment. And you're going to hear some about that later and how we've accelerated some of the work we're doing in telehealth to make it easier and safer for both our people and our patients to receive the care that they need. So I think we're excited in both of those areas. Before I invite Dr. Roberto Cardarelli to speak specifically to some of our new telehealth capabilities for patients with acute onset symptoms, and then I'm going to reintroduce Dr. Derek Forster and Kim Blanton for some general COVID updates. I just want to make a couple of comments that I think are important for people to hear. First, I know that as people listen across the country, they're hearing about limited amounts of, again, personal protective equipment or PPE. We continue on a day-to-day, week-to-week basis to evaluate that. We're going to continue to give you updates around that. But literally, like I said, every day we look and we're continuing to find additional sources and opportunities to be able to have those resources that our staff needs in order to be able to take the very highest level of care for our patients. Along those lines, I also want to thank Congressman Andy Barr, who reached out and helped us get additional releases from the Strategic National Stockpile so that we could, and we brought those into play last week so that we can have, again, more of the things that our staff need. And they do have the things that they need, and it's important that we continue to support them in that way. The second thing I wanted to talk a little bit about, as you may have heard over the weekend from Governor Beshear, we have been approved for limited testing for COVID-19. And so, as we said, and I do want to reiterate limited because, again, we're growing our capacity, and we'll talk a little bit more about that, but the in-house testing right now is for our sickest patients, but hopefully we can expand that over time. I'm sure you'll have questions on that, and we have our Chair of Pathology, Dr. Gerald Jennings, who will be available for questions as well. However, first, I'd like to start by introducing our Chair of Family Medicine, Dr. Roberto Cardarelli, who will talk to you a little bit about our expanding telehealth capabilities. Dr. Cardarelli?
Thank you so much. Good afternoon. Just to echo Dr. Newman, we're here to keep our patients, our community, and our healthcare providers safe. So as we started seeing cases roll into Kentucky, a large group went into action and in 8 days developed an acute telecare service that was launched last Wednesday. And so at our Turfling campus, we have urgent care, but we also wanted to extend telemedicine visits to those who are acutely ill for our patients. And so we are mimicking the hours of our urgent care. So we actually are starting at 8 a.m., going all the way to 9 p.m., Monday through Friday, and even Saturday hours from 9 a.m. to 3 p.m. They call a 800 toll-free 800 number, and they are given a link to through a very compliant telemedicine platform called Zoom. And we have providers staffing all these hours to help with those with acute concerns, acute symptoms. And we've been taking care of our UK healthcare patients from 3 hours away. I had cases where we are actually taking care of patients from all over the state. And in a mere 3.5 days, we have already done over 100 visits through telemedicine. And to us, that means that we're keeping patients safe at home. We're keeping our community safer by keeping people isolated who might have symptoms, and we're getting them tested that have the symptoms that we're concerned about. So we're excited to extend this offer and this service to our state, and has been an incredible success. As Dr. Newman mentioned, the number of healthcare providers, nurse practitioners, and physicians that have stepped up, many volunteering their time to cover these shifts, has been absolutely amazing. So I actually personally want to thank all of them for stepping up and caring for our patients and for people throughout the state. Happy to answer any questions.
What are some of the challenges of telehealth? You cannot physically see the patient, correct?
Well, it's video, so we can. Oh, absolutely. So we're able to assess if they're in respiratory distress, how ill they look. We ask them to take, if they have thermometers and blood pressure machines at home, to check their vitals. We even have them get close up and look at their throat if we need to. So it's a video telemedicine visit.
Is this for patients generally, or is it for patients only who think that they might have COVID-19?
No.
Let me repeat the question. So the question is this for patients generally or patients that really think they might have COVID-19?
This is right now for general. So it's all acute visits. And so even though majority of the calls are obviously symptoms, upper respiratory and lower respiratory symptoms because they're concerned, but we're taking all acute visit calls.
Other questions about telehealth before we turn it over to our infectious disease folks?
How many providers do you have who are participating in offering telehealth services?
How many providers are participating in offering telehealth services?
So right now we actually have 24 providers, APPs, nurse practitioners, and physicians who have taken shifts and volunteering their time.
Any other questions about this?
Let me just go one other. I just want to add to that. Over the next 2 weeks, we're going to be extending this out beyond urgent care to our specialty care as well. So I don't want to give it, I probably shouldn't have given you the 2-week time frame because hopefully we'll hit it. But the goal is to expand this so that people, even people who don't have acute illnesses but need to be seen for their other diseases, they could be seen without putting themselves in risk of coming in and being, too tight together with other people. So that is something we hope to, work through over the next 2 to 3 weeks.
Yeah, from the over 100 visits that you've had so far, people maybe thinking they have COVID-19, have you encouraged any of them to actually come to the hospital after seeing their symptoms?
So of the more than 100 visits so far, have you encouraged any of those to actually go to the hospital?
No, by far, almost all that I know in terms of that's been reported to me have been managed at home. Now, we may probably ask them to come for a nurse triage visit for testing, but we have not sent any to the emergency department that I'm aware of.
Any other questions about telehealth? Okay. Great, thank you, Dr. Rowe. Okay, I'm going to call up Dr. Forrester, who you know now very well, and Kim Blanton, who you know very well as well. They'll give you a bit of an update, and then we'll answer questions generally about that or other topics.
Trying to keep our distance.
Yes.
Give a quick update as far as numbers go in laboratory values and testing. So, since we first reported our first case on March 6th, that Friday, we've tested now a little bit over 900 people. Not all those test results are back, but that included a lot of the commercial send-out testing that we've talked about before from last week. And then, as was mentioned, we did start limited testing for our patients in our own laboratory. So we've had a total of 17 positives through all that. Most of the positives have been testing either through the emergency department or the ambulatory spots throughout the system. We've had 4 total admitted patients during that time. That includes the very first patient. There are 2 patients in-house today. Both are in fair condition, but that's something that we're monitoring. I'll reiterate what the governor and everybody else has said as far as the importance of social distancing, the importance of staying home if you can and you don't need to go out. This is something that we all owe to ourselves. We owe to our parents and our grandparents to stay home, to protect ourselves, to protect the community as much as we can. So I'll stop there with any questions unless Kim wants to say anything.
Any questions?
As far as I know, lately there's been over 100 cases in the state. I believe 3 deaths, 1 recovery. Is there any concern that there's only been 1 recovery thus far?
Are you concerned at all, Derek, about the recovery numbers, given the overall numbers that we've had?
Yeah, well, I think a lot of it has to do with how the reporting of recoveries go, because technically enough time has to pass for that person to be deemed recovered, and usually that's 2 weeks or so. So that will take some time for those numbers to start trickling in to actually get officially counted. That doesn't mean that they're severely ill or hospitalized or anything like that. I think we're seeing pretty similar patterns to what other places have seen so far as the numbers go and the percents that are being hospitalized and end up on needing more acute care than that. So I think that'll be something that still takes some time to play out. The numbers are coming in. So last week, for example, was the first week that we really the state had the capacity to do more extensive testing through a lot of the commercial labs that came online. Those take some time to come in, so a lot of those numbers that were trickling in last week don't necessarily reflect new cases. I mean, they are, but they're not necessarily in that time frame. It's a little bit of a guessing game as far as some of the numbers that are coming in, when they were acquired, when they became sick, et cetera, because of the way the reporting is. I think that'll start to get streamlined and start to even out and be more consistent as we move forward with turnaround times of some of these deaths going down.
Of the 900 people, you said 900. Were you talking about people who sought care here initially and then were subsequently tested? Is that where that figure comes from?
What's the composition of the 900 she's asking?
That's total across the board since March 6th.
At UK?
Mm-hmm.
Okay.
Through, not necessarily in the hospital, but through the UK system.
Okay. The 4 who were admitted, that's the total number. How many of them had to use a ventilator at any point?
Just 1.
Question was about the numbers.
Oh, sorry.
Sorry.
10 years ago, we had a different pandemic, H1N1. What did we learn from that pandemic, H1N1, and how does it compare to COVID-19?
So what did we learn from the H1N1 pandemic of a decade or so ago, and how do these compare?
Well, I think a lot has been learned as far as PPE supplies, ways to conserve that maybe weren't known before, contingency plans to put in place. All those things have been acted on through most hospitals, I think, in the U.S. And even though supply is low, most people do have supply right now because of a lot of those things. But that doesn't mean that, unless supply chain picks up, that doesn't mean that will continue. But so that's one thing. The ability to try to implement things rapidly and gain knowledge. So that's another thing as far as the amount of literature that gets put out quickly from a research standpoint in other parts of the world to help those that, we're kind of benefited by the fact that we've had the chance to see how others have responded and what's worked, and we've had a chance to get some initial literature about its spread, about some treatment options and those type of things. So I think that's all been helpful for us, but the ability to be able to quickly disseminate information, research, et cetera, those things have been learned and are valuable. You think about how quickly the virus was identified and posted to worldwide databases for other countries to use, and that was really extreme and phenomenal, but obviously that's not the only thing that will help us. But those are things I think that come to my mind that have been learned from that, and past episodes as well. The other part of your question was,
How do they compare?
How do
the
they
two
compare?
viruses?
How
Yeah.
the two compare?
Thanks, Jay. So the viruses themselves, obviously this is a different virus, but as far as the infectivity or the transmissibility, they're pretty comparable. This COVID-19 is maybe a little bit more, a little bit easier to transmit compared to some flu viruses in the past, but most of it is pretty similar. That particular thing came on so quickly that it was hard to really respond to. The difference from a vaccine standpoint is flu vaccines can be developed rather quickly as long as you know the strain. I mean, you can take pieces of the strain out, pop them into flu vaccine that's already available, and you really don't have to go through a lot of the rigorous safety data that you have to with something that's completely novel. So that is certainly one of the differences that stands out. I mean, I think for a novel flu, for example, it's estimated that you can have vaccine in circulation perhaps as quickly as 3 to 4 months, which is really really pushing it. For this is starting from scratch because we don't have things that are previously in existence for that, so that takes more time. So those are some differences that I see.
How many tests have been conducted so far and sort of processed at the state lab, and what's the turnaround time for results?
It's going to be the number of tests, process, turnaround time, and we can also bring up Dr. Jennings too.
Yeah, and Dr. Jennings might have that. So I can't speak to the state lab. I'm not sure what.
Right,
what
I
the,
meant UK,
Oh.
since you all have your processing capabilities now.
Yeah. Does anybody have a number on that?
The number of processing?
Yeah.
Yeah. I'm going to bring up Dr. Daryl Jennings, who is the chair of our Department of Pathology, who can speak to the testing process at the university.
Thank you. That's very much a work in progress. We are rapidly trying to build up our capacity. What I can confidently say is that we have sufficient capacity to test all of the patients in our outpatient clinic, our inpatients, and our emergency room here at UK. Basically, our motto is the right test for the right patient at the right time, and I think that we certainly can meet that for our UK patients. We are actively trying to expand that capacity as we speak, bring additional platforms on site as well, but that remains a work in progress.
Are you talking about COVID-19 specifically?
Yes.
Or? Okay.
Yes, specifically.
So numerically, what is that quantity?
What is
like,
that?
Approximately.
So you're asking what that quantity is approximately.
The number of tests done or the
The capability
The
and also the number of tests done so far.
well, the total is what was what Derek said, and our in-house capability depends on, say, how many tests have to be repeated. So let's say you run a batch on a set of patients right now, 90 patients. Maybe 4 or 5 of those have an indeterminate result. So then you'll come back and repeat that. So that means your next run, instead of 95 new patients, you've got to run maybe 87 new patients because what would that be? 8 of those will be repeats from the previous one. It's a sufficient number to cover all of the UK healthcare needs, both inpatient and outpatient at this point.
Other questions about the testing? Anything else we've covered?
I got a question for the doctor over here.
Question for Dr. Clark?
Are we still battling flu season? My last calculations, 24,000 cases in Kentucky, 50 deaths, last check. Is that more of a threat than COVID-19?
Is flu more of a threat than COVID-19 given the numbers?
So I think as we move forward and as we move in the next few months, COVID-19 is obviously the bigger threat now. We've seen flu season and influenza-like activities start to decrease throughout the country. Number of positive tests, percentage-wise, that the CDC tracks is going down. But we've actually seen influenza-like illness start to creep back up. Usually in a flu season, you see a bimodal pattern, meaning you have an increase, comes down a little bit, then you have a second increase, and then it goes down, and that's kind of the tail end of your flu season. We were past that second increase and going back down, and then we started to see influenza-like illnesses go back up, and the suspicion is that might be COVID-19 that's accounting for that increase. And so certainly as we move forward now, I think influenza is starting to go down. It's still going to circulate for another month or so, but we're starting to see those numbers go down, and the biggest concern right now moving forward from a respiratory virus is COVID-19.
Going off of that question, allergy season is coming up. Do you think that could be difficult also? What do you think of that?
What's the impact of allergy season on this?
So as I look at that, I think the biggest impact will be the blurring of the line of symptoms. So we'll have, you guys see things are starting to be in bloom now. I think this is still true, the allergy capital of the world, or at least of the state, of the country. So I think it will be a little bit tough. I think a lot of people will be worried about their symptoms, and is this allergies or is this something very mild or something else? Hopefully, again, this is a part where the literature comes in. Hopefully we'll be able to better discern exactly some of the symptoms, and as testing becomes more available, we'll be able to work through some of those details and nuances. But I see that as the biggest thing, is maybe some blurring of the line and concerning to people about some of their symptoms.
We've seen other hospitals around the state set up pop-up respiratory clinics. Other hospitals, I think it was one of the Nortons in Louisville, set up a tent outside basically to accommodate potential overflow. What specifically is UK doing to prepare for potential / likely overflow?
So other hospitals have set up pop-up operations or tents to handle a spike. What is UK Healthcare doing to prepare for that potential?
Sure, and some of you guys may be able to talk to it a little bit more as well. But so this is very much still a work in progress as well. But a triage system and a change of approach as far as the ED to be able to separate patients with concerning symptoms on the front end. The ability to utilize specific units to be able to care for patients, both positive and waiting for test results. And so we're working through that right now as far as getting those systems in place to be able to make space in those locations.
Okay. Is the number of isolation beds still the same? I can't remember the figure that you gave previously, Dr. Newman. What's the current number at this point?
Number of current isolation beds.
Yeah, as far as the airborne infection isolation rooms, which is what I think was talked about before, I think it's about 150 across both systems in the enterprise, including Children's Hospital. So that doesn't mean necessarily that we would use each one of those for these things, because sometimes they're used for other things as well. But those rooms are available throughout the enterprise.
Okay. Is there some sort of mechanism in place we've heard of other hospitals throughout the state potentially getting COVID patients, transferring them elsewhere? This is word of mouth. Are you guys basically the catch-all for other patients or other hospitals maybe in more rural parts of Kentucky that get patients that they think are potential COVID-19 patients? Are they sending them to you?
Are we getting a lot of referrals from rural hospitals?
No, the ones that we've had have been through our system from the beginning. So, I think the state and the health department's been communicating about this some as well. But, I think as we look forward and kind of look at the next, several months of this, I think we'll all have to be able to care for patients. Like I think every hospital in the state will have to be able to manage those as we move forward. So, at least I'm not seeing us as a catch-all location. As Dr. Newman said, we're certainly here should the need arise if the management is not able to be done appropriately at another facility, and we have the capacity to do that. I'm sure we would be willing and open to do that. But just a positive test alone, or somebody that can be hospitalized and managed in another facility, our plan right now is not to be the catch-all from that standpoint. And you guys may have anything else.
As we know that it's going to continue to get worse before it gets better, you talked about how many people are volunteering their time as far as healthcare professionals. Somebody brought up the idea of bringing retired healthcare professionals back into practice kind of during this time if needed. Is that something you guys are considering?
Is there thought about using retired our healthcare professionals to help with the workflow and management.
Yeah, I'm probably going to finally pass the baton on to Dr. Newman. I think he's got more of those answers.
I think we have to be, one of the things that, and we're having to go through this now, one of the things is you look at, if you think about which healthcare professionals you want on the front lines, we have to be careful about older people with other comorbidities. Again, pulmonary disease, again, heart disease, kidney disease, other things that would put them at risk. So, I mean, obviously one of the things we can do and we want to do with our own employees is to try to let them help, but put them in situations where their risk of infection may be lesser. So I think we look for and want the support of our community in helping us do these things, but we want them to be able to do it in a way where we're not putting them at increased risk.
Other questions?
So another question about testing. I guess can you maybe talk about like the turnaround time of like in-house testing and maybe how long that takes compared to like the state lab testing we've been using?
Sure, asking about the turnaround time of our in-house testing as opposed to other labs.
Our in-house test runs on a 96-well plate. The on-machine time for that test is between 5 and 6 hours. So basically, we would look at that as a same-day test. Now you say, well, why can't it be 6 hours? Well, that's because then we run them as we fill that plate up in sequences. So if your test comes in while that run is 3 hours in, then we got to wait 3 hours, then do the 6. So it might be 9 hours. And as I mentioned earlier, if you maybe have to repeat that sample because it was indeterminate the first time, so there'll be a second 6-hour run. So we're typically, I think, turning those around same day. Some of them may come out in as short as 7 or 8 hours, probably no more generally than 24 hours.
Is that different from state lab like procedure, I guess?
Is that different from the state lab and its procedures?
Yes. The state lab is a more manual procedure. It's the original CDC procedure. This is actually running on an automated platform which allows you to move it through.
Just a general health question, I guess, for people at home. We're hearing a lot of people are not being administered the test, but they still think they may have corona. How can their loved ones or people taking care of them help take care of them without actually contracting the virus as well?
So the question around if people think they have COVID that haven't been tested, how can family and loved ones help ensure someone?
I'll let Dr. Carter take that since he's doing that exact thing right now. This morning, correct?
Yes, this morning, exactly. So yeah, we're having a lot of cases where, obviously the symptoms are concerning, but not conclusive as we're running tests. What we're telling the patient and their families is really following the CDC guidelines and the tips, and we actually review those tips actually with the patient and their family there, from just hygiene, isolating themselves, cleaning surfaces with disinfectants, resting, plenty of fluids, symptom control, but isolating themselves, and the importance of using a mask if they're coming out to get tested, and things like that. And so, while some of them may not be tested, the best thing to do is isolate themselves if they're around a loved one that they're taking care of.
Is there any concern with everything shutting down, department stores, that people will just, instead of going to those department stores, flock to the grocery store? And there'll be too many people in the grocery store, the aisles sometimes can be narrow, that things can transmit. Although people are trying to play it safe, they still could be transmitting the virus.
So with a limited number of businesses still in operation, is there a concern about the amount of gathering that might take place and some of those still open like a grocery store?
So I think that is certainly a potential concern, that you'll have concentration of populations in the places that are open. I know a lot of places are staggering specific times for specific population groups, and I think that's a wise practice. I know the retailer that we typically visit has specific hours for older populations, and so I think those things we'll see. If you are in those locations, still follow the CDC's guidance as far as trying to stay 6 feet apart from other folks, and just be smart about when you're out there and be cautious about what you're doing when you're going places, etc. And if you have the potential to go in a time where it's not as busy, I would encourage you to do that. I would encourage you to take that opportunity. Again, that's another measure to protect yourself and other people as well.
Any last questions?
Yeah, so I saw kind of a study this morning that certain hospitals are making a test for people who've already had the virus and maybe recovered from it, just to see if their immunities are up. Is that something that you guys think that, in the future you may be thinking about?
It's a question around an immunity test.
Well, there is information coming out about the potential use of antibody testing, either to diagnose or to show immunity. That's been, there's not really enough information to know what to do with that right now. Certainly in some other disease states, you can have antibodies that are produced to represent your immune response. That doesn't necessarily mean those antibodies are protective for future infections. So I think we're still waiting on some information there, and how best to utilize that type of information moving forward.
Any last questions?
Blood donations.
Blood donations, yeah. So it'll help them off the side of blood donations.
And Dr. Jennings, if you have specifics about
The need.
Yeah, and we talked about this before as well, but still a need for blood donations through the blood banks. I think I'm not sure if there's a website or information for that, but I know a lot of the
We've got information on our coronavirus website.
Yeah,
about
okay.
blood donations and how you can do that. So uky.edu/coronavirus.
Yeah, please put that blurb out there for us. That is something that other facilities and other states and locations have seen a dramatic decrease. That's still a need. That's still a need in our community and other communities as well. And I think a lot of places have implemented processes and procedures to protect yourself while you're there and stagger that. So still definitely a need for blood donations, and if you can do that, that would be very, very much appreciated.
All right. Thank you all. Oh, do you wait for one more? All right,
last thing
Jake,
for
one
you.
more from the
I
front.
guess today starts the first day of online classes for students
Mhm.
at the university. Has the administration noticed any hiccups or challenges, anything like that?
We're going to be checking at the end of the day. Kathy Kern runs the online learning platform for the campus, and we're going to be checking in with her at the end of the day. I've not heard of any disruptions or issues, but I think we'll have more information about that in the coming days. Thank you all.